Hey there, and welcome. I'm Anna Hartman, and this is Unreal Results, a podcast where I help you get better outcomes and gain the confidence that you can help anyone, even the most complex cases. Join me as I teach about the influence of the visceral organs and the nervous system on movement, pain, and injuries, all while shifting the paradigm of what whole body assessment and treatment really looks like. I'm glad you're here. Let's dive in. Welcome back to another episode of the Unreal Results podcast. This week, the doors are open to the online LTAP Level 1 course. It's only open for 4 days. So I wanted to do another replay episode, but to give you a little intro for it, this episode, it takes you through a case of using the Locator Test Assessment Protocol and one of my clients, actually, believe it or not, in a virtual visit. This is what's cool about the LTAP, is you can use it virtually, hands off. Navigating some, what she described as originally as shoulder pain, but come to find out, talking to her and asking more questions about what's going on, seems a little bit more like costovertebral joint dysfunction type of pain. And so we utilize the LTAP to figure out what's going on, find what visceral organ is sort of driving her mechanical symptoms, look at some mechanical symptoms, and then provide her some interventions, which makes a big change in how she feels for the first time in maybe even months or years. So this was like a injury that had plagued her for a really long time, and she didn't really get a lot of relief from traditional physical therapy, traditional rehab. And so yeah, it's a perfect example of how to use the LTAP in practice. I hope you enjoy, and let me know if you have any questions about the upcoming online cohort of the LTAP Level 1 course. Her assessment, her complaint, why she wanted to do a one-on-one session with me, it was two reasons. One, she's had long-standing what she was calling shoulder pain for 5 years, right shoulder pain. That she'd, gone to all the physical therapists, massage therapists. She's a strength coach on her own. And so she's doing all the things, and nothing really ever seemed to move the needle and help her. So there was that. And then her other more recent thing was within the last 2 months, she had found herself mm, either in urgent care, the emergency room, or even return visits to those type of physicians, feeling like she may have been having a heart attack. And she obviously was very worried about that. And especially knowing that visceral diseases can cause some musculoskeletal pains. And she was having pretty severe pain through her chest. It was like straight through her chest. A little bit more left-sided. It was going up into her jaw, her kind of upper back, and it was feeling like some signs and symptoms of a heart attack. So of course, she went to the emergency room and they did all the full workup on her, and she was totally fine. So they sent her home, and but she'd still have the incidences of this pain, and and it was still like weighing on her conscious of like what's going on. Um, with that said too, though, even though she was worried about it and was like, what's going on, she also knew that there was other viscera in the area that could be bothering her. And I'll give you a little bit of her backstory. And she has some issues, digestive issues anyways. So, she knew this was a possibility, but that's why she wanted to see me, is because one, she's hoping I could help with this more acute thing. And then two, for a while, she's just wanted me to check out her shoulder. So, her background is she has an autoimmune disease. She was diagnosed, I want to say like maybe 15 years ago. And recently, within the last few months has fully gotten off her medication for it, which is huge. That is not a normal thing for autoimmune diseases, disorders, illnesses. And that's actually why I want her to come on the podcast, is to talk about her journey and her new business that she's creating all around that to help other people, um, live with their autoimmune issues and understand their body and their autoimmune issues better. So that is a little bit of her history. Like I said, she'd had this shoulder pain for like 5 years, and then this chest pain severe for a couple months. And then within the last maybe few weeks to a month, she'd been having pretty significant reflux, like gastroesophageal reflux disease or GERD symptoms. And yeah, so that's the history. When I asked her more questions, well, first of all, when I heard her symptoms of her chest, I was like, "Oh, if it's not a heart attack, what you're describing is like almost like textbook costovertebral joint pain." Whenever patients complain of the chest pain that feels like it's going through your spine, or not through your spine, but through your chest, like from your spine through your chest, or from the front of the chest to the spine, that like straight line, that is almost always a costovertebral joint dysfunction. Now, with that said, it's also symptoms of a heart attack. So, it's not necessarily something you want to ignore, but deductive reasoning can sometimes, it will sometimes make sense that it is this costovertebral joint thing. The interesting thing too, in terms of her GERD, that mid back area, and that she was having that symptom of, because like if we think about our heart is between like rib 2 and rib 6, and so it is that like mediastinal area, so the thoracic spine, and those similar areas that she was feeling that discomfort, that costovertebral joint dysfunction. The other like telltale sign was she was having increased pain with the inhalation breath, which is also very rib, like costal vertebral type of pain. So this reflex too, so the esophagus, the GERD issues, the gastroesophageal sphincter can refer into that mediastinal mid-back area, as well as into the neck and upper back. So very similar pain pattern. Her shoulder pain, at first when she said shoulder pain, I was like, "Oh, it makes sense because if you're autoimmune and because of the medicines you're on, because right shoulder pain is like almost always liver." You've heard me talk about that on the podcast many times, the few different episodes that I've shared that in. But usually if somebody says they have right shoulder pain, I'm like, it's your liver 100%. So I'm already kind of thinking esophagus and liver and costovertebral joint. But then when I talked to her more about her shoulder, where she was pointing was not shoulder. And it was actually, she was pointing to like her lap area. So it was more related to the rib and the costovertebral joint than really it was like traditional shoulder. She was just referring to it as shoulder pain because it was usually like part of her movement pattern of shoulder dominant exercises that, it didn't, feel great always on her. So that's important too. That's kind of a little lesson too, of like making sure when someone says that they have pain somewhere, you don't, you take it with a grain of salt and then have them point to it, describe it, and because if I didn't do that, I would have gone on the assumption that it was like general shoulder pain, and probably could have went down a different path. With that said, this is why the LTAP is so great, is because it takes me out of the equation of figuring out what path to go down, and it just directs me what path to go down, which is great. So I probably would have still gotten pretty good results, even though I was believing it was a liver. I probably would have just been surprised that it wasn't the liver, because of if I was assuming it was her shoulder. But once I knew it was more of her like lat rib
parascapular area, then it was like, oh yeah, this is a different referral than liver. And again, this is one of the lessons that I teach in both the results sheet code and the LTAP and the mentorship is to not be distracted by the patient's story and to be not be not be distracted by it, but not be biased by it. And so it is tough in a virtual setting because to just start with a physical assessment without in a virtual assessment is challenging. So it does take conscious practice to be not distracted by the information they're giving you. But in a virtual setting, it does help to streamline things quite a bit. If I were seeing her one-on-one in real person, in not real person, it's still real person virtual, but like in the flesh, where I could put my hands on her, I actually wouldn't have asked her where in her shoulder and stuff first because again, I don't want to be biased by it. But um, you know, sometimes that's possible and sometimes it's not possible. So that's kind of the background. So I already knew on her I wanted to assess upper extremity function and I wanted to assess like spine function or stability as my orthopedic things for her. And even head and neck control, though honestly I didn't get to it, but like in my whenever I'm like planning out my assessment, I'm like, okay, we're gonna start with the LTAP and then I want to do an orthopedic and movement assessment. And what am I going to want to look at? And so I was already kind of thinking in my head, what kind of ortho and movement stuff do I want to look at? And then the treatment is just going to be based on where the LTAP directs me and based on my ortho and movement assessment. And then what they care about. Like if she was like, care about like I'm working on improving my pull-ups, and that might be sort of something I'm like directing my interventions around, if possible. So for her though, she just really wanted to learn and wanted to feel better. So kind of an open door on that. So let's talk about her LTAP. So the LTAP is an acronym for the Locator Test Assessment Protocol. It is my signature assessment that helps me determine where to go to have the best outcomes from treatment standpoint. So where to start treatment and then what sequence to do the treatment in, right? And it gives me an indication of like if the body is in a protective pattern or not, where it is, how might this protective pattern be influencing their orthopedic and movement assessment. So in the virtual setting, this is the great part about the LTAP. It is very possible to do all of it except for the fifth test in the virtual setting. And it just takes a little bit of body awareness for your clients and you describing where you need them to assist in putting their hands as the intervention or inhibition test. So her LTAP, virtually the first test, which is what I teach in the results cheat code, is I use the March test or Gillette's test, and I'm looking to see what her SI joint mobility is like. So on her, like many people in the virtual setting, sometimes the March test can be challenging to see what you're seeing, but I knew something looked off. It wasn't clear to me yet which side was the hypomobile side until I had her hold her breath. And then when she held her breath, it changed and her movement got better. Specifically, I think it was on her right side, if I'm remembering correctly. It was hypomobile, she held her breath, and then it was mobile. So that directed me to the next test, or at least that directed me to know that, okay, that means the traffic cop is directing me that it's her protection pattern is specifically around the central nervous system or other visceral organs. And so then I did the central nervous system tension test. I looked at that on her, which I'm looking at side bending. I'm looking at anatomical landmarks in her cranium, and she did not have a central nervous system pattern. So I ruled that out, which then tells me it is one of the other visceral organs. So that leaves visceral organs of the neck, the thorax, the abdomen, or pelvis. Here in the virtual setting, this is when it's nice to sort of know their story and what's going on, because I can quickly go to the organs that I think that might be causing the problem and do an inhibition test there to confirm. And so I used standing shoulder interrotation as the test to determine if there was a protection or pattern around the organ. And so she was limited in internal rotation on her left arm. And when we inhibited specifically the upper part of her esophagus and her neck, her internal rotation went from like here to here. Like it gained probably like 30 or 40 degrees of range of motion. It was significant. The liver didn't really change it much. The stomach did a little bit, but not as much as the esophagus up in the neck. I had her inhibit the gastroesophageal sphincter itself, and it changed, but again, not as much as in the neck. And then to just prove that it was, not biased, I picked some organs that like were not as related to her symptoms. And, I tested something in her pelvis and her abdomen, and those didn't really change her shoulder internal rotation at all. So that was confirmation that this protective pattern for her was in the part of her esophagus that's in her neck. So, at this point, I pause the LTAP, right? Well, not pause. I'm at the end of the LTAP because I have identified, yes, there is a protective pattern and in the viscera, and then I've determined what specific visceral organ it is, that it was esophagus. So from there, I moved on to my orthopedic test and my movement tests. And from an orthopedic standpoint, just from a general postural standpoint, her right shoulder, the scapula was depressed and a little bit downwardly rotated. And then when I had her do shoulder flexion, she was significantly lacking upward rotation of the scapula. Her scapular inferior angle did not leave the posterior side of her body at all. Like it didn't go around the corner at all. And then her movement dysfunction was not just a lack of upward rotation, specifically on this right side, but in order to get her arm all the way up overhead, instead of the scapula upwardly rotating, protracting, upwardly rotating, it was actually going into a posterior tilt and external rotation, which also concurrently made her spine extend and rotate to that side. And so I'm like, that motion is exactly why you're having costovertebral joint pain, is because you are using excessive movement in that costovertebral joint junction around the thoracic spine to make up for shoulder flexion. And also you're really putting a lot of force, anterior force on that rib, when you're using your parascapular muscles to posterior tilt and externally rotate. And so that's going to be low trap and mid trap. And it was just driving that instability at the costovertebral joint. And then, so she was actually having two symptoms related to the ribs. She was having that straight through pain for the costovertebral joint, but the lap pain, the shoulder pain she was complaining about was kind of a wrapping around pain, which was likely like an intercostal nerve distribution pain. Both of them likely because the head of the rib was driving through that area. Let me repeat that. Likely because the head of the rib was going more anteriorly as she was going into extension and rotation to that same side, that she was moving her shoulder overhead. Now, the other interesting thing is at this level, it was likely the level of T6, which is the sort of the lower part of the mediastinum. And why this level also tends to be one that causes problems on people is because if we look at how our ground reaction forces are transferred from our feet to our head, that is the T6 is the area where the forces cross. So the force comes up our leg, crosses our SI joint, moves up the spine, and then at T6 moves over to the opposite side of the head and neck. And so T6 is just an area that tends to already have a lot of force going through it. So that coupled with it now being the way she gets her arm up overhead, it was like very, I don't want to say classic, but it was like, I wasn't surprised to see that pattern on her. So, um, I wanted because she was lacking upward rotation and because I saw um that pattern, I was curious too of like what her serratus anterior strength was. And I think one of the best ways to look at it is a single arm wall push up. And it was very, very clear. She had a very clear pattern when she did the single wall arm push up on this right side, that she was weak. And also not only was she weak in the scapular stabilizers like that, but her core was weak when she went to that right arm support. And so you saw her spine immediately extend and start to rotate to that side. So here I was able to identify like, oh, okay, she's got a little bit of serratus weakness, but also oblique weakness as well, which makes sense because the serratus anterior interdigitates with the oblique. It is basically an extension of the same muscle. So I wasn't, again, shocked to see that. But you get it exposed a little bit more in that exercise than some of the other ones. One, because it's single arm, and two, because it's a exercise people don't do a lot. So they don't know how to prepare for it, right? Because sometimes when you pick exercises like a plank or quadruped or like things that are already familiar to them, especially movement professionals, they'll be like, "Oh, she's watching me. I better do this correctly." And sometimes you'll get like false information. The single arm wall push up, like it's just not something that people commonly do. And so it's a really good test in that aspect to see um, real quickly some patterns of what's going on. Um, so then I felt like at this point I had a pretty good list of orthopedic things I was wanting to see change. So one, it was just the dynamic alignment and static posture of her uh, upper extremity girdle. And then two, it was the shoulder flexion, both single arm and double arm. I was seeing this pattern on, and then a single arm wall push up to see a little bit more of the strength and performance side of it. So then we started treatment where the LTAP directed us, which was at her esophagus here. And I actually chose, so up in your neck area here, the esophagus is intimately connected to the trachea. They're within the same visceral sheath or visceral container. And so I chose to do more of a little bit more of, I guess, intervention that you would associate with the trachea than the esophagus. But knowing that they're in the same place, I was like, let's do it together and just see what happens. Also, too, because in my own body, in my own experience, I know that my reflux is worse when my asthma is worse. And they're very intimately connected in that standpoint, too. I have no doubt that some inflammatory things that happen within one structure to the other get sort of intermeshed and influence each other. So the first thing I chose for her was gargling. And that was proved to be a difficult task for her. And gargling, so she gargled for a little bit and then I retested her shoulder flexion. And it was actually improved quite it was improved, but I was like, I feel like we could get more out of this. So then I tried humming. At first, I tried humming while she was lifting her arms up overhead, and that was it had her thinking too much. And because at this point I had already pointed out some of the movement faults she had, and so she was trying to do too much at once. So I saw that in her body language, and so I said, "Forget the arm flexion part of it. Let's just hum, and then I want you humming in different octaves," and that's hard for people to conceptualize. So I was like, "Let's hum a song together." So we hummed Happy Birthday, we hummed Twinkle Twinkle Little Star was her other choice, which I loved because, side note, in the 3rd grade for the talent show, I played Twinkle Twinkle Little Star on the piano, and I was, like, so nervous and so proud of myself, and then I got made fun of by people, like, these bullies, when I would wait for the, bus stop. They would sing Twinkle Twinkle Little Star to me and, like, ride their bikes around me and laughing at me. I'm like, but even though I have a little, like, trauma with that, it still is one of my favorite songs, so those bullies didn't ruin it for me, but that is sadly what I remember. Anyways, that was a side note. So we hummed together, which, this is an even more powerful thing. So the humming for her, humming is, obviously more trachea-based. It technically can be considered a, glossopharyngeal nerve activator or stimulator or whatever you wanna call it. But me doing it with her also is social engagement and autonomic nervous system regulation, like we're co-regulating together, which is very good for the nervous system. And so I was kind of getting a 2-4-1 with her. But she hummed and then we retested, and boy, did that change her dynamic alignment of her shoulder quite a bit. Her whole shoulder came back up in some elevation and some protraction. And then, therefore, when she lifted her arm up over the head, she had a little bit better upward rotation and a little bit less spine extension and rotation. And then we went over to the wall for the single arm push up, and she had way less of a movement fault in, her core control, and, she was able to do, like, 2 or 3 reps before her serratus really fatigued, so I loved to see that. Um, and then I taught her we were running out of time, so then I taught her the exercise I wanted to do. I'm like, "Hey, here's the thing. 1, you're gonna do some prone thoracic breathing on the ball, maybe neck anew, and then the humming. And then I want you to do this exercise called cross leg lift, which is an exercise that really targets the serratus anterior and puts the spine in a curve. So facilitates obliques as well. So it connects obliques and serratus anterior. It's one of my favorite ways to get upward rotation and better spine mechanics for the upper extremity to move on. So I taught her that. She did 3 or 4 on each side and was very tired because when you are weak, this exposes it. And then we rechecked shoulder flexion and the wall push up, and everything looked so much better. And then my advice to her, besides adding in the humming, the restoration of her thoracic curve, and this cross leg lift, was I wanted her to lift a little heavier in her workouts because I needed her to improve her core stiffness to help this. Because she's always, given her autoimmune history and her challenge with her immune system having this excessive inflammatory pattern, and her liver still processing 15 years of medicine and, like, all the things, right? She's going to have a tendency towards these visceral, protection patterns, and so I want her spine to be less responsive to it, if that makes sense, meaning less, manipulated by it. Her costovertebral joint in that area was easily manipulated by it because it lacking stiffness around the joint. The joint is hypermobile from years of driving motion through it. I'm not gonna fix that, right? That's just how it is. The only thing that's gonna fix that is stop moving through it so much. We're going to stop moving through it so much by giving it more stiffness. So the long-term game is manage these symptoms, do these exercises to increase stiffness around the area. So then when your esophagus gets irritated again, we're less likely to get so hypermobile through that joint. So, and then also part of the pain pattern probably was a little bit referred pain too, but there was a big mechanical piece. But the mechanical piece was there because of some of the protection modes. So it's like we're layering all of these things together. So not only did I ask her to lift a little bit heavier, I wanted her the intensity about 7 out of 10, 7, 8 out of 10 intensity. So lower the reps down, increase the weight as needed. And then I asked her to add in suitcase carries because that's probably one of my favorite exercises for improving oblique stiffness. So, and the only other request I had, which I hate telling people not to do things, but she really does not have the scapular mobility and strength at this point to do overhead pressing exercises. And so I was like, for now, let's let the cross leg lift upward rotation exercise be your overhead pressing. And then as your core gets stronger, as your mobility and your strength get a little bit better, and just you understand where your relationship of your scapula and your spine are in space, then we can talk about adding in upward rotation as an overhead pressing as an exercise back into her program. So that was it. It was like a 70-minute session, and I left her on her way. And then she messaged me the following week and was like, I feel so much better. She's like, for the first time in like 5 years, I haven't had that shoulder or lat pain. And she's like, and my reflex feels so much better. And she was just so happy. And it's just, again, like pointing out, when you know where to start, it just makes it so much easier. So thank you to her for allowing me to share this story, because I think it is a really powerful example of the connection between visceral and musculoskeletal, and then also a really good example of using the LTAP in action and assessment. And then also a great example of doing it virtually, So I know a lot of us help people virtually, and or are movement professionals that want to help people in a more specific and precise way. And so this is a great example of that. So that's it. I'll link the video that I shared on Instagram about this in the show notes, as well as the cross leg lift exercise, and maybe the prone breathing. I don't know. I think I linked that before. And that's it. I hope you enjoyed.